Hello, everybody, and welcome to today's webinar in the Public Health webinar series on blood disorders. This webinar is presented by the Division of Blood Disorders at the U.S. Centers for Disease Control and Prevention, also known as the CDC. I'm Julie Jaffray. I'm a pediatric hematologist at Rady Children's Hospital in San Diego and a clinical assistant professor in the Department of Pediatrics at UC San Diego. In addition, I'm the current president of the Thrombosis and Hemostasis Societies of North America and co-leader of the hospital-acquired VTE prevention with the Children's Hospital Solutions for Patient Safety. I'm delighted to join you guys today to moderate this session. Leading today's sessions are two distinguished researchers who will share latest findings on two multi-center trials on the prevention and treatment of pediatric venous thrombosis. First, I'd like to introduce to you Dr. Neil Goldenberg. He's a professor and global principal investigator of the Kids-DOTT trial. He also serves as Associate Dean for Research and directs the Johns Hopkins All Children's Institute for Clinical and Translational Research at Johns Hopkins All Children's Hospital. Our second speaker is Dr. Tony Sochet. He's the national principal investigator of the COVAC-TP trial, which he'll talk to us about today. Dr. Sochet is an assistant professor of anesthesiology and critical care medicine at Johns Hopkins University School of Medicine and the associate director of pediatric critical care fellowship program at Johns Hopkins All Children's. So just some housekeeping, and we're going to do a quick poll. Today's webinar is going to take approximately 1 hour. The session will be recorded, which you can go back and listen to later. Please note that at the end of the presentation, there will be time for questions. To submit a written question, use the questions area of your toolbar. We will respond to as many as we have time for. Okay, so we're going to begin with two brief audience polls. We're just interested in knowing more about you. Please select your response to the poll question. The first one is, which of the following best describes you? All right, so it looks like most of us are a healthcare provider. All right, we have a second question. Which region of the world are you from today? And I heard we have people from around the world, so please select one. All right, and it looks like 90% of us are from North America, so hopefully we're all in the middle of our day and pretty awake. So thank you all for participating in these polls. It's really helpful for us to learn about our audience. And let's move to the presentation. Dr. Goldenberg, welcome, and let's begin.
Thank you so much. Thank you. It's a pleasure to be here with you all today, and a real honor to be joined by expert colleagues, Dr. Sochet and Dr. Jaffray. Our learning objectives today are to describe the incidence, risk factors, and outcomes of VTE in children, to identify historical knowledge gaps in pediatric VTE treatment and prevention, to describe the latest evidence on optimal duration of anticoagulation for the treatment of provoked VTE in patients younger than 21 years of age, and to describe the safety of enoxaparin thromboprophylaxis in children hospitalized for COVID-19. Our outline for today, I'll begin by introducing the pediatric VTE landscape by describing definitions for VTE, the incidence of VTE in children, and very briefly, the treatment and outcomes of VTE, leaving a discussion of the risk factors for VTE for Dr. Sochet, paired with his discussion of the COVAC-TP trial findings and design. I'll then move into the Kids-DOTT multinational phase 3 randomized clinical trial background, design features, findings, and limitations and unanswered questions. And I'll try to emphasize in the design component of the discussion some of the innovative approaches that were employed. Then Dr. Sochet will present a background, as I mentioned, risk factors, but also the aims and rationale for the COVAC-TP trial, its design findings, and limitations and unanswered questions. By way of disclosure, I receive research support from NIH as well as salary support and have a number of consultancy roles in the design and oversight of industry-sponsored antithrombotic trials in children, some of which are managed through an academic research organization. Dr. Sochet receives research support from Johns Hopkins All Children's Hospital Foundation and some salary support from NIH without consultancy roles to disclose. So it's a real pleasure to talk to you about key findings from recent investigator-initiated multicenter trials in pediatric venous thromboembolism treatment and prevention. And in talking about the Kids-DOTT trial and the COVAC-TP trials, we really need to first define what is VTE that we're discussing here for children. And VTE really comprises both deep venous thrombosis and pulmonary embolism. And DVT itself includes deep venous thrombosis at multiple potential locations and organ sites, including the limbs, pelvic and chest locations, abdominal and splanchnic venous circulations, the inferior and superior vena cava, the right atrium, which one often not think of as venous, but given the common predisposition in children of a central venous catheter extending toward the right atrium, this is part of the VTE grouping of underlying anatomic sites. And also something that is not always considered in the inclusive definition of VTE is that in many of our VTE studies and publications, we discuss cerebral venous sinus thrombosis, also known as cerebral sinovenous thrombosis. And so VTE includes all of those as well as pulmonary embolism. The incidence of VTE in children is really marked by two peaks, one in the neonatal period and another in the teen period, the adolescent age range. And by comparison to an overall incidence across the pediatric age range of approximately 11 in 100,000 children per year overall, in young adults 18 to 40 years of age, that incidence is around 60 per 100,000. At the same time, the incidence of pediatric VTE and or its rate of diagnosis has been markedly increasing during the new millennium, and in the last 20 years, as you can see in this graphic from the more recent publication by Sarah O'Brien, Leslie Ruffini, and colleagues, the incidence and or rate of diagnosis has steadily increased from 2001 to 2019. So this problem is very topical and important, not just among adults, but in children as well, and hence the focus on clinical trial evidence to inform practice. So what is the treatment? What is our practice? The mainstay of therapy for pediatric VTE is anticoagulation. The key evidence, however, is derived from early randomized clinical trials in adults, originally adults with PE with or without proximal deep vein thrombosis of the limb. And those early studies, such as the study of Barrett and Jordan in the Lancet in 1960, showed a risk reduction associated with anticoagulation and the risk of VTE, predominantly PE-related death, or of new PE events. Subsequently, trials in the field that have usually not been placebo-controlled since that time, studying various approaches to anticoagulation, different agents, have looked at recurrent VTE and VTE-related death as key outcomes. With regard to outcomes, a number of registry studies and observational cohort studies have been conducted over the last more than 20 years. And I show here on this sampled table of publications, not all inclusive, that the rates of recurrent VTE in children in these studies have ranged from as low as 2% to as high as 8%, but some of the additional studies, particularly ones that were retrospective in nature have had frequencies exceeding 10%. Of course, the follow-up duration is important and varied across studies, and the one-year outcome rates are often in this age range as well, and many clinical trials have used even a shorter duration of follow-up of 3-month or 6-month outcome rates. With regard to major or clinically relevant bleeding, these studies that I refer to for recurrent VTE rates have often not reported the rate of major or clinically relevant bleeding, although 2 of the recent clinical trials, multinational in nature, with the direct oral anticoagulants, have reported a frequency of 3% for the combination of major and clinically relevant non-major bleeds at 3 to 4 months of follow-up. We also consider chronic venous insufficiency as an important sequela of deep vein thrombosis of the limbs and of the vena cava and pelvic and chest vasculature that support drainage of the limbs, upper or lower extremities, in our studies of pediatric VTE. And meta-analysis in 2010, as well as more recent in 2020, have looked at the overall rate of post-thrombotic syndrome, chronic venous insufficiency following DVT of the limbs at 1 year or greater from time of the diagnosis of the DVT. And the rates of chronic venous insufficiency are quite high, ranging from 26% to 40% or higher, and among prospective studies appears to be about 1 in 3 patients thus far, based on a relatively small number of studies that have systematically collected these data. Also recognizing that post-thrombotic syndrome is a syndrome with variable severity and phenotype, and a few different validated tools can be used to evaluate that outcome. So what are some of the key unmet needs? One is how can we safely prevent VTE progression or recurrence among those who have incident acute VTE events, those children who do so. In other words, how can we optimize the net clinical benefit of the efficacy in preventing progression or recurrence at the cost of bleeding safety? And what is the optimal duration of anticoagulation for VTE treatment that optimizes that net clinical benefit? Secondly, how can we safely prevent VTE events in the first place, so-called incident VTE events, among patients who are at highest risk for those events, optimizing the net clinical benefit in terms of VTE risk reduction efficacy versus bleeding safety, bleeding harm? What are the optimal subpopulation or scenarios to target for safe VTE prevention? In other words, risk stratified thromboprophylaxis, and what anticoagulant regimens are safe and effective in these indications? These are all unmet needs currently, and the trials that we will discuss now have strived to answer some of these questions, at least to advance the field. So what was the Kids-DOTT study? By way of background, in terms of who, what, when, where, how, and why, we start with the why. Kids-DOTT trial was conducted to inform the standard of care on duration of anticoagulation for VTE treatment in young patients under 21 years of age. It was an RCT on duration of anticoagulation, studying a 6-week total duration versus a 3-month total duration. And it was conceived in early 2000 with its first planning grant in 2004. A number of grants since that time, including NIH funding, took it all the way to completion of the primary endpoint analyses in 2021. And it was conducted at 51 centers in the US, Canada, Europe, and Australia via a parallel cohort RCT design, probe design, and non-inferiority design. And we'll talk a little bit about a few of those things momentarily. It was comprised of a pilot phase with several different sources of grant funding, and then a rest of trial phase. And I think that's an important feature that we'll touch on in a moment as well, in terms of validating some of the key assumptions for the definitive RCT during the pre-specified pilot phase of the study. In terms of current status, the database lock occurred in 2022 for secondary endpoints, which are 2-year outcomes. I'll show you in a moment the overall study schema. The 1-year outcomes have been published, and as you see here, a number of publications were generated thus far, including the trial design as a parallel cohort randomized controlled trial, the bivariate endpoint method that I'll touch on momentarily, the pilot findings that I just alluded to, and so forth, including the primary RCT findings in JAMA in 2022. So what was the study design? In terms of eligibility criteria, children with acute VTE confirmed radiologically within the past 30 days. Children was defined as under 21 years of age, and a provoking factor had been identified by the investigator. Those were the inclusion criteria. And children with a prior VTE who had thrombolytic therapy for the index VTE, or who had clinically significant protein CS or any thrombin deficiency, as shown here by way of thresholds, were excluded. There were some additional exclusion criteria as well. These were the main exclusion criteria. In terms of design, without going through all the details of what is otherwise a somewhat busy figure, children were enrolled within 30 days of diagnosis, underwent repeat imaging at 6 weeks post-diagnosis for assessment of the degree of occlusion of thrombosis. And those children who had complete veno-occlusion at the 6-week time point were not eligible for randomization, but were followed on a parallel cohort for complete veno-occlusive thrombosis and received a 3-month duration of therapy consistent with the standard of care. Whereas those who did not have complete venous occlusion at the 6-week mark were randomized to either discontinue therapy after completing the 6-week course versus to continue on for the historical conventional 3-month total course. However, children who had had positive antiphospholipid antibody testing at diagnosis did have repeat testing of APAs at the 6-week mark, and at that point, if they were persistently positive, those children were not randomized either, but were followed on a second parallel cohort for persistent APA. And the rationale for those 2 parallel cohorts was that during the planning and design phase, the investigators group felt that there was lack of equipoise to randomize children who had completely occlusive thrombi with the concern that they might have adverse outcomes if their conventional therapy was shortened. Similarly, that children with persistent APA at 6 weeks, at which point randomization were to occur, could go on to meet criteria for antiphospholipid syndrome if their antibodies were still persistent at the 12-week post-diagnosis mark, and that such children were felt to be possibly at increased risk for recurrent VTE, and similarly were felt not to be good candidates for randomization. And so given the paucity of information, especially from rigorous multicenter studies in pediatrics for those 2 scenarios, we did not want to exclude those children from study. We wanted to exclude them from randomization. And so the parallel cohort design was an efficient approach to gain longitudinal data on children followed in a similar fashion, and then generate separate analyses and manuscripts describing natural history in those 2 populations. Children were followed at 3 months, 6 months, 1 year, and 2 years, and the primary endpoint was at 1 year. The primary efficacy outcome was symptomatic recurrent VTE occurring within 1 year of diagnosis of the index VTE. And the primary safety outcome was clinically relevant bleeding, which is defined as major or clinically relevant non-major bleeding. And this too was within 1 year of diagnosis of index VTE. The outcomes were adjudicated by an independent blinded clinical endpoint adjudication committee, and these definitions were modeled after the ISTH pediatric trial criteria for thrombosis studies outcome definitions from the SSC. The analytic plan involved testing the primary hypothesis of non-inferiority in two ways. One is in a per protocol analysis, and the other was in an intention to treat analysis. And we stated that a positive trial, in other words, supporting a hypothesis of non-inferiority, would require that both the per protocol and the ITT analyses supported a conclusion of non-inferiority. The per protocol population was comprised of all randomized patients without eligibility violations who had adhered to the assigned treatment duration, 80 to 120% of assigned doses, and who had completed at least 6 months of follow-up. The analysis of the 1-year estimated risk was based on Kaplan-Meier analysis, so kids could have had as little as 6 months of follow-up, and as you'll see, follow-up extended to the secondary endpoints to as long as 2 years of follow-up. The ITT population, more simply, was all randomized patients. So an innovative aspect of the trial in terms of analysis was something called a bivariate endpoint analysis, developed by Dr. John Kittleson and colleagues at the University of Colorado. And this really was an optimal method for the study of anticoagulation in VTE and other anticoagulant uses, or quote unquote indications, because anticoagulation reflects a trade-off of bleeding harm versus risk reduction in thrombotic events. And clinically, we do consider both risks inherently and simultaneously when making this risk-benefit, net clinical benefit decision in terms of giving more or lesser therapy, or more intense or less intense therapy. Kittleson and colleagues developed an approach to modeling that net clinical benefit through the bivariate endpoint analysis, where simultaneously those two endpoints of efficacy and safety could be shown in a two-dimensional space. And these are bivariate curves, non-inferiority curves, that allow one to decide and operationalize those criteria in a study as to a conclusion of non-inferiority, in favor or not in favor of non-inferiority. And we show 3 representative curves here. One of the advantages of the Kids-DOTT design was to be able to evaluate during the pilot phase rates of endpoints while maintaining the blind in order to finalize these statistical parameters of that bivariate curve for the future decision at the end of the definitive trial. And so one of the challenges in conducting RCTs is that too often we don't have robust data that supports the assumptions that we make statistically when designing those trials. And so what will be our randomization and retention rates? What are our rates of the primary efficacy and safety outcomes? And is the information we have from prior data directly related to the target population in our trial? And so Kids-DOTT employed a pilot phase to be able to validate those assumptions, and those data were published in 2015, informing the final power and sample size of the study, but also validating a key assumption of the inter-rater reliability of that radiologic determination at 6 weeks that I alluded to earlier in the study schema, which is that there is high inter-rater reliability in a simple discernment of complete veno-occlusion, yes, no, radiologically by ultrasound and other modalities that were permissible for protocol. So this allowed us to demonstrate that with our design, we would have 81% power to be able to conclude non-inferiority if we had sufficient number of events. It's an event-driven study, so we estimated that we would need approximately 312 patients in the protocol population to achieve the requisite number of events. And we knew that in the ITT population, we would have far more than the 312, and therefore would be more than sufficiently powered to address the question in the ITT. So we published these findings in 2022 with a very insightful editorial provided as well in JAMA from a group out of San Justine, speaking as much to the statistical methodology, I think, as to some of the other aspects of the findings clinically. And I'll share just a brief synopsis of those before concluding this portion of the talk. And that is that we had 417 randomized patients and 115 who fell into those two parallel cohorts that are the subject of future publication. Those 417 randomized patients then filtered into 154 and 143 in the two arms of the per protocol population in terms of shortened duration versus conventional duration therapy. And I will show you here now some of the characteristics at baseline in the population, the per protocol population, in terms of age, a median age of around 8.5 years, with distribution of neonate, child, and teenagers shown here because those were the a priori strata for randomization by age group in the trial to strive to achieve balance at those age group levels. We had approximately half male, half female, slight variance around that within each grouping of treatment arm. And you can see in terms of race that we had approximately 13% of the patient being Black and approximately 13 to 14% being of Hispanic or Latino ethnicity. Predominantly, about 75% of the patient population had extremity DVT, but as you can see, around 12% had cerebral sinovenous thrombosis, as I mentioned at the beginning in terms of types of VTE. And we had a variety of other sites for thrombosis as well, less frequent than those categories. And in terms of provoking factors, as we see commonly clinically, a central venous catheter or an infectious disease, trauma, flare of autoimmune disease, prothrombotic medication, et cetera, were some of the more common provoking factors. In terms of the primary and secondary endpoints, showing you the per protocol analysis data, the adjudicated symptomatic recurrent VTE rates were quite similar, with a very small absolute risk difference between groups of 0.04%, with numerically actually a lower rate of events in the shorter duration arm. And this just shows you that statistically by chance, we wouldn't think biologically we would expect that shortened therapy would be associated with a more favorable risk, but concluding here that before we get to the formal bivariate, that there was no appreciable difference here in outcomes between those two arms for efficacy. And then for safety, clinically relevant bleeding in the per protocol analysis, again, no discernible difference in outcome rates, an absolute risk difference of minus 0.05%, again, lower risk numerically in the shorter duration arm as one would expect biologically and clinically. In terms of the primary analysis, the non-inferiority analysis by bivariate method, what I show you here are the bivariate rectangles, which are the 95% confidence interval rectangles, because we are in a two-dimensional plane. Normally one's used to seeing an interval on one plane, and here we have confidence rectangles. And as I alluded to, we needed to see that these 95% confidence rectangles lied within the conclusion of non-inferiority for both a per protocol and ITT. And in this two-dimensional space in the bivariate analysis, this means that these confidence rectangles had to both be in the lower left quadrant as opposed to the upper right quadrant relative to the non-inferiority bound without crossing over that bound. And these were concordant and conclusive in terms of non-inferiority. So there are a number of limitations and unanswered questions. One is that patients with proximal or isolated PE were excluded from the Kids-DOTT trial. And so the question remains, what is the optimal duration of anticoagulation for PE in patients under 21 years of age? And One of the Kids-DOTT investigators and colleagues, Dr. Rajprakash, and colleagues are developing a multicenter cohort study on pediatric PE that will be conducted through the International Pediatric Thrombosis Network to hope to inform a future feasibility and design of an RCT on this question. Another issue around the Kids-DOTT trial was that the screen to enrolled ratio was approximately 3.5 to 1. And how well will these findings hold up in real world experience? We have submitted an R01 application to address this very question, to look at the outcomes of shortened duration therapy and real world experience in a large global observational study. Hopefully we will receive funding and be able to address that important question. Thirdly, the Kids-DOTT trial preceded the rapid uptake as well as the regulatory agency approvals of the direct oral anticoagulants for pediatric VTE treatment. How well will these findings hold up in the era of the DOACs? And again, if we're able to conduct a real world evidence Kids-DOTT follow-up study, we will be able to evaluate that question as well. And then a fourth item is that these children with persistent phospholipid antibodies were excluded from the RCT, but followed in a parallel cohort. And so do they have a higher risk of recurrent VTE? Do they have a similar bleeding risk as those without persistent APA? Dr. Batensky here at Hopkins is leading a pre-specified analysis from that cohort with the manuscript in preparation. And there are a number of subgroups of interest in this study, which was broad for VTE in terms of the specific subtypes of VTE. And these secondary manuscripts are planned to address descriptive analyses, mostly in these subpopulations of interest. So I'm going to now turn the second part of the presentation over to Dr. Sochet.
All right, thank you, Neil, for all the work you've done and getting a piggyback off of this and shifting gears to a different subpopulation of interest. I think over the last 3 years, we've been very familiar with how the world has changed post the COVID-19 pandemic, and to date, as of at least last week, and the cumulative counts that are kept track of by WHO, we've almost reached 1 billion people, or on our way towards that, who've been infected, with a death toll that's around 7 million. And while at first, when the pandemic was being published on, and when reports from Europe and Asia, there was a thought that maybe this was predominantly an adult-related disease with children largely spared, which to some extent is not untrue. When we look at some morbidity and mortality weekly data from probably the year after 2021, we see that not only were children being affected, but rather their hospitalization rate and the ICU rate of admission for the specific subpopulation was quite high. Let's see if I can change slides. Here we go. So to the extent of those children who are hospitalized within that time frame of a month or two in 2021, 16% required respiratory support beyond just regular oxygen, 8% required vasoactives, and the mortality rate was almost 2%, which for a critical care population is actually quite high and above the average, for almost 4 times that of the general mortality rate for ICU encounters. And if taking a step back and piggybacking again on Dr. Goldenberg's discussion about VTE risk factors, when we think about risk in critical illness and conceptually within the triad of Virchow, there are many competing factors in critically ill children and hospitalized children, or I should say concurrent and maybe added risk for each one of those. So if a child comes into the ICU, they're mechanically ventilated, they have a central line placed, they're iatrogenically or purposely immobilized, and they usually have an underlying inflammatory process, all of which add to some degree, or theoretically add to some degree, to the risk of venous stasis and thrombosis. Dr. Jaffrey had published data regarding that specific risk within the ICU population recently in pediatric critical care medicine, and over a variety of risk factors that are related to the rates of VTE in children who develop VTE after hospitalization. We'll focus on the last one of those, which is underlying infection, inflammation, or autoimmune illness, which the infection related to COVID-19 and also the inflammatory effects after that in children, a specific phenotype called multisystem inflammatory syndrome in children, were highly related to the development of VTE in this population. When we look at adults and VTE risk with related to COVID-19, and also if the presence of anticoagulation results in or benefits those patients, a variety of reports have also shown that not only were the VTEs extremely high in that critically ill subpopulation, but also that the presence of anticoagulation as prophylaxis may in certain subpopulations be insufficient. And therefore, highly recommending the use of thromboprophylaxis for this specific group. For children, for some reason, let's see, I think I missed a slide. Let me see. Trying to go backwards.
Can I advance it for you?
It's just slow on my end. I don't know if it's working that way on your end. But this is published data from, I think, 17 or 18 different centers, with our center included, that also looked at between children who had COVID-19, a classic respiratory-based phenotype versus MIS-C, and those with asymptomatic SARS-CoV-2 infection. The rates of VTE are actually quite high and dramatically high in the teenage group with MIS-C. And we were seeing this also early on in the pandemic, that children were being hospitalized with coagulopathy, both hyper and hypocoagulopathy, but with significant rates, elevated rates anecdotally with VTE, pulmonary embolism, and limb DVT. And then this same report, you can see that there was a variety of reported practices from these centers with regards to the use of thromboprophylaxis, whether it was low molecular weight heparins or unfractionated heparins or other. And so at the time, we participated and drafted in the ISTH guidelines or recommendations, consensus-based recommendations for thromboprophylaxis for children with COVID-19, that recommended the application of thromboprophylaxis in this patient population, in particular patients with elevated D-dimers or superimposed risk factors for VTE. But at the same time, recognize that there are limitations of this was the complete absence of phased trial data in specific populations in children, let alone those with COVID-19 illness. And so that recommended that we need data on this, and this is exactly what our trial sought to accomplish moving forward. And so our study design was, the primary aim was to determine what was the cumulative incidence of clinically relevant bleeding defined by SDH, to assess the dosing strategy applied in the trial, which commonly applied in other pediatric subpopulations, to determine if we achieved a anti-10A level, low molecular weight anti-10A level associated with thromboprophylaxis, or to achieve thromboprophylaxis from that standpoint. And then also from a safety standpoint, or from a safety and now efficacy standpoint, what the cumulative incidence of VTE were in these patients, because one thought is that perhaps that prophylaxis alone is still insufficient in this group as well. And so we rapidly initiated a open label, non-randomized, multi-center phase 2 trial conducted at 8 centers in the United States, starting around May to June of 2020, enrolling children 0 to 17 years of age who were hospitalized with either primary COVID-19 infection or MIS-C presentations. And again, the intervention was twice daily enoxaparin. We excluded children for otherwise typical reasons for weighing the risk benefit of applying an anticoagulant. So if patients had severe coagulopathy, renal impairment, or already had a clinically relevant bleed, they were not approached for enrollment. The primary endpoint, again, was the cumulative incidence of clinically relevant bleeding. And then in that time period, we screened to 300 patients. We enrolled 260, or went through and excluded 262 and enrolled 40 children into a study, of which 38 were included in the analytic set, which was what was needed to power our study to assess, again, our cumulative incidence of clinical relevant bleeding events. And what we found, and then in this table, we kind of broke off groups that had COVID-19 versus MISC in a planned analysis as part of study, is that there are some interesting differences, I suppose, within, although that didn't show up as well, with regards to the degree of inflammation, or as assessed by a variety of molecular metrics, but also the patient size and weight were variable based on their primary COVID-19 infection versus MISC, which has also been the experience of across the country for children who had MISC infection tended to have a different clinical presentation. Ultimately, we found that a majority of the patients, 35 of 38, actually achieved prophylactic anti-10A levels that within the pre-described dosing strategy that was part of trial. There were no clinically relevant bleeding events observed throughout the study period for all enrollees. And for the most part, there was a clinically negligible but slightly different dosing requirement for those patients who had a primary COVID-19 infection versus MISC. There were no serious adverse events related to the study that were documented related to drug. We did have 2 children who, despite the presence of thromboprophylaxis, did still have a venous thromboembolism. And these VTE occurred even after goal anti-10A levels were documented. And so, there are limitations and unanswered questions, as with the Kids-DOTT trial, as with every trial, that perhaps patients who have the occurrence of breakthrough VTE in this subgroup brings the question again whether or not different dosing intensity strategies are required for not only the COVID-19 population, but other populations that are receiving anticoagulants as thromboprophylaxis. And that there are several secondary analyses that are underway and were intended as part of this trial that include a more comprehensive analysis of the plasma proteomics, the expression of single cell leukocytes collected as PBMCs as part of this study, and a variety of other thromboinflammatory assessments that are ongoing and actually at this point in manuscript preparation format. And I think I'll pass the baton back over to Dr. Jaffrey for a question and answer session.
All right. Well, thank you both for those wonderful presentations. Hopefully you can see me. There we go. So we're now going to shift to the question and answer section of the webinar. Again, please submit written questions. Use the questions area of your toolbar. We're going to try to get to as many as we can. So I do want to start. Maybe Neil, do you want to start as we are getting the questions in? Some highlights, the few of the success factors of doing these trials?
Yeah, I think it really bears a lot of emphasis that there's such a great challenge to doing multi-center trials, especially in children, and then much less, as Dr. Sochet and a large collaborative team did, conducting them in the midst of a pandemic. But secondly, in the example of Kids-DOTT, doing a long duration trial where the follow-up period of the trial for many of the patients was during a pandemic, and how do you retain patients to follow up and endpoint capture. And so one thing that was really critical was our ability to be adaptive and even proactive with regard to conducting remote visits for those things that were amenable to being ascertained remotely. And the Kids-DOTT trial before the pandemic had a provision for how the long-term follow-ups could be conducted remotely with any events then verified as to obtaining information on any recurrent VTEs, bleeding, et cetera, obviously one would have to forego for those remote visits a physical exam for a post-thrombotic syndrome assessment, chronic venous insufficiency, but that was a secondary endpoint. So that was an important success factor, and I think Dr. Sochet can also address that. But I think a really important one overall, as you saw with Kids-DOTT, was funding mechanisms can be extremely challenging in large, ambitious, academically driven trials. And for Kids-DOTT, it took multiple funding mechanisms. It was really critical that we were able to have philanthropy be part of that equation, in our case through the institutional research grant program mechanism through the Johns Hopkins All Children's Foundation here in St. Petersburg, Florida, but clearly the NIH funding in a development award and then ultimately 2 UO1 investigator awards for clinical coordinating center and data coordinating center were critical, and some critical bridge funding for Kids-DOTT from the American Society of Hematology, as well as some of the other awards. So it really takes a lot of funding support, and philanthropy is really a critical piece of the equation very commonly in these academically driven studies. And then a third key success factor is having a highly willing group and network of investigators who really recognize the importance of the problem of VTE in young patients. And I think that's super important that patients, and thank you to advocacy groups who really take on this charge, is in many cases with help from folks like us to really get the word out that this is something that occurs in children. It can be life-threatening in children. What are the signs and symptoms of VTE? But also, please consider participating in a study where we can learn more for the benefit of future children. And really, the participation in both of these trials was quite selfless, given that the benefit is to future patients more than to the patients who enroll themselves, as we're generating new knowledge that informs practice.
Thank you, Dr. Goldenberg, for that. I think that was a really nice highlight of what we've done, but also what we need to do. And, we're also grateful for the CDC to have this webinar. One interesting question from the audience, there's two parts to it, and it's really directed at you, Dr. Goldenberg. So this person noticed that you had very few cardiac patients in your Kids-DOTT trial. And the first part of the question is, can you comment on why that might be? And because, as you know, we have a large number of patients that are cardiac issues and have blood clots. And then they go on to say, one question they get frequently for their cardiac surgeons, I love this, is why treat these DVTs? And, they want to know, how would you respond and convince your surgical team that perhaps clots in cardiac kids is a problem?
Yeah, unfortunately, the second part is a very long answer, but I'll try to be brief on that one. The first part, I'm really glad that was pointed out, because I did not list all the exclusion criteria, and I did not, in the unanswered questions and limitations, give an exhaustive list. And that is one that's worth mentioning as well, is many children who have underlying congenital heart disease in particular, who undergo surgical interventions, are perceived to require a long-term anticoagulant and for thromboprophylaxis because of their a priori risk. And much like we thought with the antiphospholipid syndrome scenario, the completely occlusive at 6 weeks scenario, children with severe anticoagulant deficiencies who were an exclusion. One could debate about whether pulmonary embolism is really an exclusion, or if it just kind of is a more worrisome presentation. But in any case, many types of heart disease were felt to, because of a standard clinical practice of longer anticoagulant therapy or prevention, therefore not meet criteria for this shortened duration acute treatment of VTE study. And I think that's an important area for future study. There have been some direct oral anticoagulant trials addressing safety and efficacy measures, not randomized and blinded, or at least not blinded, in populations of interest. And so I wouldn't point to Kids-DOTT or COVAC-TP for that, but that population is very important, and I'm so thankful it has received attention. One of the more recent publications has been the Ennoble ATE trial using edoxaban and reporting on prevention of new thromboembolic events in those patients who are at high risk a priori. Why treat the DVT really quickly? I think we recognize that number one, having a deep venous thrombosis can result in chronic venous insufficiency, and we don't know that anticoagulant therapy reduces that risk necessarily. Prevention of a clot in the first place, by definition, would prevent PTS, since PTS is defined as chronic venous insufficiency related to a prior DVT. But also there's loss of venous access that's very important, especially in a population that really requires frequent line placement or diagnostic catheter, cardiac catheterization. Having a thrombosed, vessel is one less place for access for interventional or diagnostic procedures. And there's active work through the International Society on Thrombosis and Hemostasis Pediatric Subcommittee to evaluate what are the long-term outcomes, sequelae of these quote-unquote asymptomatic as well as symptomatic events.
And I think along the same vein, your work on optimizing the duration of therapy on the other end of that spectrum, it's rather difficult on the enrollment end on clinical trials for thromboprophylaxis because of the same reasons mentioned by that question of trying to convince someone who may or may not see the risk of bleeding or VTE, or maybe outweighs bleeding versus the presence of a venous thromboembolism. The other thing that I found interesting in conducting our trial, Neil, was the reluctance of many family members early on in a situation where they're under a lot of duress to consent to a research study that may put their child at risk for bleeding. There's something about the concept of bleeding that families struggle with, even if they're not medically savvy or have a lot of insight into that. And in particular, in thromboprophylaxis, the goal would be to apply that therapy as early as humanly possible so that you could then see if the event rate is actually reduced, not just from the presence of the hospital stay in and of itself or the etiology that brought them in. And so I think that's another challenge that thromboprophylaxis trials will have to continue to overcome with enrollment strategies and the way that we approach families.
Yeah, and to piggyback a little bit on that, on what do you do with those surgeons? We met with them at my hospital and kind of came up with a plan together, and we target a lower anti-10A level, still therapeutic, but on the lower side of therapeutic. And do I know that that's really based on a lot of research that targeting the lower end of the therapeutic is going to have less bleeding? No, but if that's how we can work together, then I think we're making steps forward. I do want to put out a question specifically to Dr. Sochet's trial. The question is, did your patients in the trial also receive mechanical prophylaxis as well as pharmaceutical? And and I also kind of wanted to know, what are we all doing now in our practice with COVID that apparently isn't ever going away? So.
Yeah, it's fascinating, Julie, because to answer your question first, halfway through our trial, a majority of the centers adopted the practice of applying anticoagulation regardless. So it started off as a study that was an interventional trial that was not standard care at each of the centers. And by the time the first, second, or third month of enrollment had gone on, almost every site had, within the study period for sure, adopted the practice of anticoagulating patients when they present with, and majority of those patients were hospitalized children in the ICU setting. So critically ill children with COVID get anticoagulation at this point. And ironically, there was no data to support that practice until our trial came out this past year in publication format. So as that highlights so many issues within many of our fields with the adoption of practice before appropriate science has been conducted to support the use of those therapies. But remind me again the exact wording of the first question.
I think they wanted to know if, I can't remember if you collected data if we were using mechanical prophylaxis with the, okay.
Common question because of the lack of superiority or non-inferiority against mechanical prophylaxis versus anticoagulant-based prophylaxis none in this specific context with COVID-19 and children. and very few within the critical illness in children also to help guide clinicians. We did keep track of it. There was no differences or at least there's no differences between the MISC group versus the non-MIC group. We follow a policy, as many others do, that have an age-based and other risk factor assessment tool that helps determine the safety of anticoagulation. We did not pre-specify that sites had to or did not have to apply mechanical prophylaxis as a concurrent therapy to or prohibit them from being part of the trial as a result of that. So I cannot comment to the degree of how that may or may not have influenced our data, but it's an exciting area to study in the future.
Yeah, for sure. One interesting question is, to any of us, can you comment on the new ISTH safety definitions for pediatric VTE treatment trials and how those may impact future trials in our children?
So that's a great point. I think it's exciting, to be able to refresh those definitions that were published in 2011, and some of the deficiencies and why, we and our colleagues were motivated to really do that work. But some of the deficiencies of the initial outcome definitions really surrounded granularity of some of the other bleeding definitions that may be important clinically, and yet were not as clear as to whether they're included in a definition of clinically relevant bleeding. And so without going kind of into exhaustive detail, because I think that deserves some devoted presentation and probably in another forum, some attention to what is important to patients and ascertaining what is patient important bleeding was one of the areas emphasized for future work and for incorporation in future studies once those outcomes can be better developed, is what is patient important bleeding. And a second one is the better characterization of heavy menstrual bleeding and how that would fit into a definition of clinically relevant. The clinically relevant definition historically was pretty simple to say if the patient sought intervention for that bleeding, then it was clinically important. But also in a pandemic and endemic period, and hopefully, as you could say, post-pandemic, right? We are now, as patients and providers, much more engaged in remote visits. And so what constitute, seeking medical intervention? Is a phone call seeking medical intervention, or is it, physically appearing at an urgent care or, an outpatient clinic, et cetera? And so a little bit more clarity around that issue and what types of changes in management for heavy menstrual bleeding would constitute a clinician's definition of clinically relevant. But again, keeping in mind wanting to also ascertain patient important bleeding and start to look at that in our studies over time as we evolve our outcome definitions.
Yeah, I think we're all trying to bring a little bit more of the actual patient experience and their opinions into our medical practice. It's a good. I'm going to have one last question because I think this is really interesting and important, and this goes to you, Neil. So it sounds like this member is saying that they had real trepidation in their division to stop at 6 weeks anticoagulation in patients with cerebral sinus venous thromboses based on the finding, just because there were not a lot of those patients. And wanted to know your thoughts on that, and are all DVTs created equal? And Scott, it's such a great question for us as we're really implementing your study outcomes.
Yeah, it's a fantastic point, and I think we have to be cautious about any subpopulations that are, relatively small in number within an overall trial. And so, I think one needs to apply the Kids-DOTT findings with caution among patients with CSVT. I think certainly when patients have ongoing prothrombotic risk factors, one should consider continuing some degree of secondary prevention, even if one is stopping at 6 weeks. And I think that goes even beyond the CSVT population. There is a separate analysis being led by Dr. Hope Wilson at UAB and the Kids-DOTT investigators to look at the secondary anticoagulant use, because it was allowed for brief episodes in the Kids-DOTT trial over 2 years of follow-up during periods of increased prothrombotic risk. And many of us are doing that in clinical practice. So I think it's very difficult to know for CSVT. It's one of the reasons why I'm also passionate about the real world evidence study, because as we use some creative statistical approaches and have more large studies, we will have many more patients with CSVT than just Kids-DOTT who are treated for 6 weeks. And if those are high quality data collected prospectively, even if not randomized, we can then aggregate those data with those in Kids-DOTT in an RCT and start to do some innovative analyses to make us feel more comfortable in the degree of data we have in CSVT patients. So it's a long answer to say we're really not sure, and I think we should be cautious in applying. It would not certainly be wrong to use 3 months in patients with CSVT, but I think the Kids-DOTT data support also a use of 6 weeks. And I think in these areas, even when we think we have clear evidence, having a conversation with the family about their values and preferences is really important. There are many families who, as you mentioned, are very afraid of the bleeding consequences and will want to stop therapy as early as you will feel there is evidence to support it. And there are others who very much fear the recurrence of an event and even are very reticent to stop at 3 months. And so I think, describing the evidence to the family and having them weigh in on an informed decision is really probably the best recipe.
Thank you. Thank you, both of you. And, we really want to thank all of you for joining us here today. And we want to thank our colleagues at the National Blood Clot Alliance for hosting today's webinar. Very shortly, you're going to receive an email asking for your feedback, so please respond to that with comments. If you have any additional questions about today's presentation, please contact Cynthia Sayers at CSAYERS@cdc.gov. Today's webinar, as I said, will be archived, and the content will soon be available on the CDC's Division of Blood Disorders website, as shown on the slide. Thank you for joining us today, and everyone have a great afternoon or evening or morning, wherever you're coming in from.
Thank you.
Thank you.